Hello, everyone. Thank you so much for joining us again this Wednesday. I hope you're having a great day. We're going to give it just a moment before we get started. All right. Hello. Thank you so much for joining us this Wednesday. We are very excited for this presentation. I'm going to give it just one more moment before we get started. All right. Well, good afternoon, everyone. Thank you for joining us once again for our weekly Wednesday webinar series. Today's webinar is on markers of autoimmunity in immune thrombocytopenia. I hope I pronounced that right. Did I do that right? Yes. Okay, great. My name is Alsen Murtha, and I'm the Manager of Strategic Communications here at the National Hemophilia Foundation. At any point during the webinar, if you would like to ask a question, please use the Q&A feature at the bottom of your screen. We have NHF staff members monitoring these questions, which we will post to our speaker after the presentation. This webinar is being recorded and will be available to the community beginning Friday, August 5th. I am joined today by Dr. Marie Hollenhorst. Thank you for taking the time to join us. I'll go ahead and turn it over to you to get started.
Great. Thank you so much for the intro, and thanks so much for the opportunity to present at this webinar. I'm going to begin by giving some background about immune thrombocytopenia, or ITP, and then I'm going to discuss what was known about autoimmune markers in ITP before my colleagues and I performed a retrospective analysis of autoimmune markers in ITP. And I'll spend most of the talk discussing our results from that retrospective analysis. Then I'll discuss two pertinent follow-up studies which have been done following our publication of those results, as well as some thoughts on implications of these results for the care of patients with ITP. And then I'll give a brief vignette at the end about some ideas regarding the potential role of glycosylation in the ITP autoimmune response. ITP is a rare hematologic illness. The prevalence is approximately 12 out of 100,000 adults. This is an acquired autoimmune disorder, and it's characterized by thrombocytopenia or low platelet count. As a result of the low platelet count, patients with ITP are at increased risk of bleeding. And this low platelet count can also manifest with some characteristic physical exam findings that I'm showing in the images here, petechiae and purpura. Perhaps somewhat unexpectedly, given that patients with ITP have a low platelet count, they can actually also be at increased risk of blood clot formation or thrombosis. And the pathophysiology of thrombosis in ITP is not well understood. So here I'm showing the normal physiologic method of regulation of platelet count. So the liver produces a hormone called thrombopoietin, or TPO, and this stimulates bone marrow production of platelets from their precursor cells, megakaryocytes, which reside in the bone marrow. The platelets which form from the megakaryocytes then circulate in the peripheral blood. And these platelets, when they become aged or damaged, they can then be removed from the circulation by clearance in the spleen. In ITP, we have a low platelet count that arises from both decreased platelet production in the bone marrow and increased peripheral destruction of platelets. And we know that a really important part of the pathophysiology of ITP is pathologic platelet autoantibodies. These antibodies bind to the platelets and trigger their accelerated destruction in the spleen. You might think that given that we know that these pathologic platelet autoantibodies are critical to the pathogenesis of ITP, that this would make a really easy and readily available clinical test for ITP. However, in general, while clinically available tests are available for testing of platelet autoantibodies, these are not generally incorporated into clinical practice. And this is because these tests tend to be expensive and time consuming, oftentimes requiring send out to reference laboratories. And additionally, these have previously been thought to lack sensitivity and specificity for the diagnosis of ITP. I'll come back to this concept a little bit later in the talk to discuss some emerging data which changes some of what I've listed here on the slide. So while a lot of the focus in ITP is on these antiplatelet autoantibodies, there's been a rising understanding that ITP is a more complex syndrome of immune dysregulation, with autoimmunity extending beyond simply antiplatelet autoantibodies. And in fact, it's been shown prior to our work that ITP patients can commonly have autoimmune markers beyond just antiplatelet antibodies, including these three that I'm listing here as an example: anti-nuclear antibody, which I'll be abbreviating ANA during this presentation, lupus anticoagulant, or LAC, and direct antiglobulin test, or DAT. And importantly, while these various different autoimmune markers are classically associated with particular autoimmune conditions, so for example, ANA is classically associated with lupus, and we know that a subset of ITP patients can have both ITP and another autoimmune illness, we also know that there is a proportion of ITP patients that have these autoimmune markers without the corresponding clinical manifestations of the related autoimmune condition. So there are ITP patients who have a positive ANA but do not exhibit the clinical features of lupus, or ITP patients with a positive DAT that don't have the hemolytic anemia that is commonly associated with a positive DAT. And so this has led many in the field to wonder if these other autoimmune markers aren't necessarily causing any clinical features of another autoimmune illness. What is it that they are doing, and what do these autoantibodies tell us about a patient's ITP disease course? Can these autoantibodies be helpful in determining the patient's risk of development of certain clinical outcomes? Or is there any other way in which the positivity for these markers can be helpful and when we're managing patients with ITP? And unfortunately, because ITP is a rare illness, it's hard to study these types of questions in large cohorts where we have robust statistical power to look for associations between autoimmune markers and disease outcomes of interest. And so a lot of the research in this field has been contradictory, with small studies pointing in one direction or another, and without really conclusive determination of what these autoantibodies really mean. And so this led myself and my co-authors to want to perform a retrospective analysis of autoimmune markers in ITP. And I had the advantage of working with Hani Al-Samkari and David Cooter, hematologists at Massachusetts General Hospital. And Dr. Cooter has maintained an ITP center at MGH for a number of decades and has closely tracked data, both laboratory data and clinical data, from the patients under his care at the MGH ITP Center, allowing us the opportunity to interrogate some of these questions in one of the largest cohorts of ITP patients that's available for study. And so we worked together to ask two questions. One, how prevalent are autoimmune markers in patients with ITP? And two, is there an association between autoimmune marker positivity and certain clinical outcomes of interest in ITP patients? So thrombosis, ITP remission. And we also wanted to look to see if there was any association between these other non-platelet autoimmune markers and the immune response against platelets themselves, so the platelet autoantibody positivity. And so in order to carry out this analysis, we performed a retrospective chart review study. These were all patients from the MGH ITP Center, so it was a single center study. Only adult patients are seen there, so we only looked at adult patients, and we selected out only those patients with primary ITP. Patients were evaluated that were seen in the center between 1992 and 2015. And we specifically looked at patients with no known autoimmune disease aside from ITP at diagnosis or during follow-up. And These patients over the years were routinely tested for a panel of autoimmune markers that I'll show you on the next slide. In addition, some patients, but only select patients, were tested for antiplatelet autoantibodies. We evaluated for two outcomes of interest. The first is remission, which we defined as a platelet count greater than 30,000 per microliter at the time of the most recent follow-up. The patient needed to be on no medications directed towards ITP and never have had a splenectomy. Our thrombosis outcome we defined as patients with deep vein thrombosis, pulmonary embolism, embolic stroke, myocardial infarction, and lower extremity arterial thromboembolism, which we assessed on the basis of chart review. Here are the 7 autoimmune markers that were routinely measured in these patients. And on the left, I've put the full name, and on the right, the abbreviation that I'll be using during this presentation. So I already discussed anti-nuclear antibody, which is an autoimmune marker classically associated with lupus, and I'll be referring to this as ANA. And of note, the ANA can be detected at various different titers. And we set a particular titer threshold to consider an ANA positive if it was greater than or equal to 1 to 40. And later you'll see why I'm highlighting that here. I already also mentioned direct antiglobulin test, which is classically positive in autoimmune hemolytic anemia, and I'll be referring to that as DAT. Antithyroid peroxidase antibodies, I'll be abbreviating as seen here, and these are classically associated with thyroid autoimmune illness. Anticardiolipin, IgM, and IgG are classically found in the antiphospholipid antibody syndrome. Rheumatoid factor, or RF, classically found in rheumatoid arthritis, and lupus anticoagulant, which I already mentioned, or LAC, which is classically found in the antiphospholipid antibody syndrome. So between 1992 and 2015, a total of 452 distinct patients were seen at the MGH ITP clinic. 157 of those fulfilled our criteria for evaluation in this study. The age of the patients was a mean of 48, plus or minus 18 years, and 60% of the patients were female. At the time of their initial evaluation, about half of the patients, 49%, were on ITP therapy, and 15% had undergone splenectomy. One advantage of our study, in addition to our relatively large cohort of ITP patients, is our relatively long duration of follow-up with a mean of 5 years plus or minus a standard deviation of 4, allowing us to assess for some of the outcomes that may occur later in a patient's ITP course. So I mentioned that one of our initial questions was how prevalent are these different autoimmune markers in ITP patients? And we found that, in fact, these autoimmune markers were quite prevalent in our cohort. So 121 out of 157 patients, that is 77%, were positive for one or more of the tested autoimmune markers. Because this was a retrospective study and testing was done in a clinical environment, the testing was not uniform across all of the patients. So not all of them, actually far from all of them, had all 7 autoimmune markers checked. Only 35 of the patients in the cohort had all 7 autoimmune markers tested. But among those 35, 89% were positive for one or more marker, 54% were positive for 2 or more markers, and 23% were positive for 3 or more. So next, we wanted to look at which of the specific autoimmune markers were the most prevalent. And we found that anti-nuclear antibody, or ANA, was the most prevalent, with 65% of our patients being ANA positive. The second most prevalent was antithyroid peroxidase antibody. This was found in 31% of the patients. And then after that was direct antiglobulin test in 29% of the patients. We were then curious to look at to what degree do the tests overlap. So if you have an individual patient, is it likely that they would be positive for ANA and DAT and antithyroid peroxidase antibody, or is it likely that they would be positive for just one or just the other? And so here I'm displaying data where we're looking at the overlap between these three most prevalent autoimmune markers. So there were 67 patients in our cohort where we had information for each of these three markers. And of those 67 patients, 73% were positive for one or more of the three markers. And so it's those patients that are displayed in this Venn diagram. And then of note, 57% had more than one, so two or more markers that were positive. And you can see that, interestingly, the pattern is kind of all over the map. We have some patients who are positive just for ANA, just for DAT, or just for antithyroid peroxidase antibody. And then we also have some patients that are double positive, as well as patients that are triple positive for ANA, DAT, and antithyroid peroxidase antibody. Here, I'm just fleshing out the data for the other autoimmune markers that we also looked at in our study. So anticardiolipin, IgM, and IgG, those were 16% and 13% of the cohort were positive. Lupus anticoagulant was found in 11% and rheumatoid factor in 9%. And I will say that while one of the limitations of our study is that we don't have a control group of healthy individuals that's matched to our ITP cohort in order to directly compare rates of autoimmune marker positivity, generally, the rates of autoimmune marker positivity that we saw, especially for our top three, were much higher than the rates that have been reported in other studies of positivity for these autoimmune markers in healthy populations. And so we do think that in ITP, these autoimmune markers are more prevalent compared with in a healthy population. So next, we wanted to look at those clinical outcomes of interest that I mentioned, so thrombosis and remission. And I'll start with thrombosis here. So in our overall cohort of 157 patients, we identified 19 or 12% of patients that had a thrombosis at any point in their course. 12 patients had only venous events, 3 patients had only arterial events, and 4 patients had both arterial and venous events. We were able to compute an event rate of 1.6 thrombotic events per 100 patient years of follow-up. And this event rate squares nicely with other analyses of thrombotic event rates in ITP patients published by others, suggesting that I think our patient population and our methods of analyzing and following them is in line with other clinical studies of ITP. So next, we wanted to look for possible statistical associations between our autoimmune markers and thrombosis. In order to do this, we used a linear regression analysis where we used several variables that we thought could be associated with thrombosis. So this included age, sex, and splenectomy status. And then we tested for statistical association between our autoimmune markers of interest and a thrombosis outcome. Here, I'm highlighting lupus anticoagulant, which by our regression analysis, we noted to be statistically associated with thrombosis with a p-value of 0.005. For ANA, because our marker negative patients had a 0% rate of thrombosis, we weren't able to use multiple logistic regression analysis, and instead we turned to chi-square testing. And there again, we saw a statistically significant association between ANA and thrombosis. Here we had 18% of patients that were ANA positive who had thrombosis at any point during their course, compared with 0% in those that were marker negative. For the remaining markers, we didn't detect any statistically significant relationship between the autoimmune marker and the thrombotic outcome. So in order to further analyze the potential association between ANA positivity and thrombosis in these patients, we also performed a Kaplan-Meier survival curve analysis. So here on the x-axis, we have years of follow-up, and on the y-axis, we have the percentage of patients that were free from thrombosis at each time. In blue, we're plotting those patients who were ANA negative, and you can see that in those patients, none of them ever developed a thrombosis, as I already showed you. And then in red, we see those patients that were ANA positive. And by our Kaplan-Meier survival analysis, the p-value was 0.02, suggesting a statistically significant association between ANA and thrombosis in ITP patients. And these results were perhaps not too surprising in the context of prior work by Natorska et al. That had been published in 2018. So these authors looked at a cohort of patients with venous thromboembolism. These were non-ITP patients, and they compared their patients with venous thromboembolism with a healthy control population. And they found that the prevalence of a positive ANA was 5 times higher in the patients with venous thromboembolism compared with controls. And so I think that this suggests that perhaps ANA is a risk factor for thrombosis, both in the context of ITP as well as outside of the context of ITP. So next, we turn to looking at ITP remission status. And so first, at the time of most recent follow-up, 50% of our cohort were in remission according to the criteria that I told you about earlier, which was including a platelet count greater than 30, not on any medications, and never having had a prior splenectomy. So we did the same type of regression analysis here to look for associations between our autoimmune markers of interest and remission status. And here we noted an inverse statistically significant relation between antithyroid peroxidase antibody and ITP remission. So for patients that had the antithyroid peroxidase antibody, 34% of them were in remission at the time of most recent follow-up, compared with 59% of those who were marker negative. And this was statistically significant with a p-value of 0.017, so suggesting that antithyroid peroxidase may be an adverse marker of ITP remission. Finally, we wanted to look at platelet autoantibodies in our study population. And so I mentioned that we had platelet autoantibody assay results only for a subset of these patients. So 33 of the patients had that laboratory testing available. 26 of these patients had active ITP at the time of testing, and 7 were in full clinical remission with a normal platelet count at the time of testing. The prevalence of autoantibodies among patients with active ITP was 73%. We looked for any statistical association between the platelet autoantibody positivity and any of our other autoimmune markers, and there was no relationship that we could detect. And I'll come back to some follow-up work on platelet autoantibody testing done by my co-authors a little bit later in the talk. But I think a notable thing for us was that there was quite a high rate of platelet autoantibody positivity in our cohort with active ITP, so suggesting that maybe the sensitivity of this test is not as poor as people may have thought previously. So here are the conclusions from this retrospective analysis. So our first question was how prevalent are autoimmune markers in patients with ITP? And our answer is quite prevalent. 77% of our patients had at least one of these 7 autoimmune markers positive. And I think this really supports and deepens our understanding of ITP as a syndrome of broad immune dysregulation, extending beyond just simply an autoimmune response against platelets. Furthermore, is there an association between autoimmune marker positivity and our few different outcomes that I mentioned? So first, thrombosis. So I think that our work suggests that ANA and lupus anticoagulant may be associated with thrombosis in ITP patients. I will caution that I think validation of these results are needed in independent cohorts, ideally in large, prospectively evaluated cohorts of patients with ITP, in order to determine if this is truly a real association. I think that this does raise the question of whether measuring ANA and lupus anticoagulant could potentially be useful when considering a patient for therapy with thrombopoietin-receptor agonists, given that we know that the TPO-RAs can increase our patient's risk of a thrombotic outcome. Maybe it would be helpful in order to be able to stratify these patients into those at higher and lower risk of thrombosis, which currently we don't have any other great way of doing. So secondly, what about autoimmune markers and remission? Well, we have some preliminary evidence that anti-thyroid peroxidase antibody could potentially be associated with a lower remission rate. Again, this requires further study to validate, but it raises the question of whether testing anti-thyroid peroxidase antibody could potentially be useful when deciding on second-line therapy or when making decisions about whether or not to proceed to splenectomy. And finally, did we see any association between our autoimmune markers and antiplatelet antibodies? No, but I'll tell you a little bit about some of the exciting follow-up work on antiplatelet antibody testing in ITP done by my co-authors. Okay, so now for the follow-up studies and implications for management of patients with ITP. So here I'm showing you a commentary that was written to Blood Advances in response to our paper by Moulis et al. And these were investigators from the CARMEN investigator group. This is a multi-center prospective registry in France where they're evaluating a similarly sized cohort of ITP patients compared with the cohort that we analyzed. And they specifically looked in their cohort at ANA and thrombosis. So they had ANA results available for 215 patients with ITP, and they found that 43% of their patients were ANA positive. Notably, I mentioned that we used a ANA threshold of 1 to 40. They used a higher threshold of 1 to 160 to define ANA positivity. Well, when they then looked for any association between ANA positivity and thrombosis, they saw no difference. I think there are two potential reasons why our results may differ. One, as I highlighted, is we were using different ANA titer thresholds. We did go back and look at our data, stratifying our patients by ANA titer. And one thing that we found, which is reassuring, is that when we drew our cutoff for ANA positivity, also at 1 to 160, our rate of ANA positivity is 41%. So it compares quite favorably with the CARMEN registry data, suggesting that I think we're all hitting on similar values, at least for the proportion of patients that are ANA positive. We also went back and looked at our patients in terms of their thrombotic risk, stratified by ANA titer, and we did not notice any major differences, although our N was quite low. We didn't notice any major differences in thrombotic risk according to the titer. You might think that thrombotic risk could be higher the titer of the ANA, but we didn't see any such trend. But I'll note again, the N was low, so it's hard to draw any firm conclusions from that. Even when we repeat our analysis, restricting our analysis to patients greater than 1 to 160, we still do see the same association that we saw in our broader cohort. So I think the ANA titer threshold may not be the whole story, but it's certainly something that I think is important to think about in future studies of ANA and ITP. Furthermore, this cohort, they didn't report their mean length of follow-up, but their cohort has only been followed since 2013. And so presumably their duration of follow-up was shorter than that in our analysis. And the authors mentioned that in those patients that were followed longer out, they started to see a suggestion of a correlation between ANA positivity and thrombosis risk. So perhaps if you continued to follow those patients out longer, this risk may accumulate over time, and maybe you need longer follow-up to see those differences. So I think it will be very interesting to look for further results from the CARMEN registry and see if with longer duration of follow-up, do they see any similar findings to what we saw in our analysis. So the second follow-up paper that I wanted to highlight is a paper, the first author was Hani Al-Samkari, who was one of my co-authors from the retrospective analysis, and Dr. Cooter, our mentor, was also a senior author on this paper. So here they wanted to re-evaluate clinical use of platelet autoantibody testing. So I mentioned in the beginning that it's sort of surprising that platelet autoantibodies are well known to be part of ITP pathophysiology, but yet clinically, we don't routinely test for platelet autoantibodies when making the diagnosis of ITP. The reason why Hanny and colleagues thought it would be useful to go back and reevaluate the utility of this type of testing is that a lot of the earlier studies, which had been reported to say that the sensitivity and specificity of platelet autoantibodies is low for ITP, were done at a time when we didn't have great standards for both the clinical diagnosis of ITP and the laboratory use of platelet autoantibody tests. And so Hanny and colleagues went back and reanalyzed the clinical utility of these tests using patients that were evaluated according to modern clinical ITP diagnostic criteria, according to the American Society of Hematology 2011 guidelines, as well as using platelet autoantibody testing done according to International Society for Thrombosis and Hemostasis 2012 guidelines. And in fact, they found in their analysis that actually there was pretty good sensitivity and specificity when using these modern clinical and laboratory criteria. So they found a sensitivity for a positive assay for diagnosis of ITP of 90% and a specificity of 78%. Their positive predictive value was 90% and negative predictive value is 78%. So I think these are actually pretty good test characteristics. And I think that this argues that platelet autoantibody testing may be useful to start to think about incorporating more broadly in our diagnosis of ITP. So next, I wanted to talk about what current guidelines say about autoantibody testing in ITP. So there are two major current guidelines for evaluation and management of ITP patients. The first is the International Consensus Report from 2019. Both of these were published in Blood Advances. And here they list under a category of, quote, tests of potential utility. So these are not tests that they think you necessarily need to do, but sort of ones that you can consider checking for an individual patient. They list DAT, ANA, and platelet autoantibodies. They also list anticardiolipin and lupus anticoagulant, and they note that these can be considered if there are features of antiphospholipid antibody syndrome. The American Society of Hematology 2019 guidelines make no recommendation for autoimmune marker or platelet autoantibody testing. I just wanted to give my personal opinion on ITP autoantibody testing after being involved in this study and reviewing some of the other data in this field. I really think we need more data to determine the clinical utility of ANA, lupus anticoagulant, and antithyroperoxidase antibody. I would not routinely use these for all comers with ITP at this time. Of course, I think we would still consider these if we had a patient where we suspected the corresponding autoimmune disease, but I think these are probably not well validated enough, and we don't have enough information on their clinical utility to broadly implement them in practice. In contrast, I think that platelet autoantibody testing, when performed as done in Hanny's paper with ASH 2011 clinical criteria and ISTH 2012 laboratory methods, I think this testing is sensitive and specific. And I have started to implement platelet autoantibody testing into my practice, usually not for just any case of ITP diagnosis, but in cases where making the diagnosis is challenging or we have a lot of diagnostic uncertainty. I wouldn't completely hang my hat on this result, but I would say that the platelet autoantibody testing could be useful to incorporate into our broader clinical and laboratory evaluation for a patient with an uncertain cause of thrombocytopenia. So finally, I wanted to give just a brief story about the potential role of glycosylation in the ITP autoimmune response, and this is connected to work that I've been doing more recently. So platelets and megakaryocytes are heavily glycosylated. That means that these cells, or in the case of platelets, cell fragments, are decorated with carbohydrate polymers that we refer to as glycans. Glycans we canonically depict as these chains where each of the shapes in the chain represents a particular sugar monomer or monosaccharide. And we depict these monosaccharides as shapes of particular colors. I'm showing you some representative monosaccharides here. Glycans can be found on the surface of cells attached to different biomolecules, but commonly they can be attached to glycoproteins. So here I'm showing in black a protein or polypeptide that you could imagine at the surface of a platelet. And then I'm showing the glycan that modifies that protein. There are different types of protein glycosylation, and one that I'm focusing on here is called O-glycosylation. That is where you have modification at particular amino acids, in this case serine or threonine, that are called glycosides. So the glycoside is the particular amino acid that is modified by a glycan. And so how do we know that platelets and megakaryocytes are heavily glycosylated? Well, some of the earliest evidence to point towards that came from electron microscopy studies that were done all the way back in the 1960s. And here I'm showing you an image of a platelet, and all of this fuzzy black stuff at the top is glycan. And I think you can imagine that a platelet that's covered in this fuzzy glycan, necessarily this glycan is probably important for the interactions between this platelet and any other cells or proteins that it interacts with in the bloodstream. So where do glycans come in with ITP? Well, one piece of evidence that supports relevance for glycans and ITP comes from this recent blood paper published from Karen Hoffmeister's research group. So here they looked at patient sera from a cohort of pediatric patients with ITP. And they found that these patients had anti-glycan antibodies that were not found, or at least not found as abundantly, in the sera of healthy patients. They characterized the anti-glycan antibody specificities, and they found a few different anti-glycan antibodies, but I'm going to focus here on antibodies that they found directed against a particular glycan called the TF antigen, which can be represented as these two shapes. It's a disaccharide, or two different sugars linked together as shown here. In their paper, they did some further mechanistic study of the potential role of these anti-TF antigens in suppressing the production of platelets in mouse bone marrow. I had some additional questions about the possible role of anti-glycan antibodies in ITP. So can anti-glycan antibodies, in addition to the work that suggests that they can potentially suppress production of platelets in the bone marrow, can they also mediate clearance of platelets peripherally in ITP? And I think if we were going to postulate that that's going on, we would think that the TF antigen must be found on the surface of platelets. So that was one small question, can we identify TF antigen on the surface of platelets? And then further, if TF antigen is on the surface of platelets, what glycoproteins carry this protein, or excuse me, this glycan? And so this relates to some recent work that we recently posted as a preprint on the preprint server bioRxiv. And this was done with a large group of collaborators, including Katie Tiemeyer, who works with me in Carolyn Bertozzi's lab at Stanford, as well as our colleague Stacy Mollikar, who is a former Bertozzi group member now, who has established her own lab at Yale, as well as other members of Stacy's lab and Kazuhiro Aoki and colleagues at University of Georgia. And we analyzed the platelet glycoprotein GP1B alpha, which I will note, we know that there are anti-GP1B antibodies in patients with ITP. And we were interested in trying to determine what are all of the different glycan structures that are attached to GP1B. And one particular question of interest would be, does GP1B alpha actually carry the TF antigen, which we know seems to be an important epitope in the context of ITP? So here I'm showing the amino acid sequence of GP1B alpha. So all of these different letters represents the different amino acids that are part of the polypeptide backbone of this protein. And then I have indicated in these glycan structures, which are in brackets, the glycan structures that we identified at particular glycosites. And if you scan through this, you can see that at a number of glycosites, we actually see that TF antigen, that disaccharide represented by a yellow circle and yellow square attached to each other. So you can see, for example, here, and many others, we see that TF antigen. And so to me, this is really interesting. And this is the first time that we have been able to definitively localize TF antigen to a particular protein or other biomolecule at the platelet surface. And I think this really begs the question, is GP1B alpha a target for anti-glycan antibodies in ITP? And more broadly, we typically think about these ITP antiplatelet antibodies in terms of their specificity for particular glycoproteins. But does the ITP autoantibody specificity depend not just on the protein, but actually on particular carbohydrate epitopes that are present on these individual proteins? And so I think those are still active questions, but ones that I think are really interesting in considering going forward and potentially could help us to develop better diagnostics for ITP or gain further insight into the pathophysiology of ITP in regards to antiplatelet and anti-glycan antibodies. And so with that, I'll conclude and give you some of what I think are the pertinent points from this talk. So our study and others have shown that there's a high prevalence of autoimmune markers in patients with ITP. In our retrospective analysis of ITP patients, we observed some interesting associations. We saw that thrombosis was associated with lupus anticoagulant and anti-nuclear antibody positivity. And we saw lower incidence of remission in patients that were anti-thyroid peroxidase antibody positive. ANA may be associated with thrombotic risk in both ITP patients as well as non-ITP patients, as shown by others. And I think it's important that further evaluation of autoimmune markers in ITP patients is pursued in order to determine their potential clinical utility. I also highlighted work which suggests that when performed in accordance with modern ASH and ISTH guidelines, platelet autoantibody testing is sensitive and specific for ITP diagnosis. And then I think it's potentially an emerging area of research interest that autoantibodies in ITP may target specific glycan epitopes on the platelet surface. And so with that, I would like to thank some of the people that I've already mentioned who I've been working with on these projects. First, for the MGH hematologist that I worked with on the ITP study, Hani Al-Samkari and David Cooter. And I would like to mention that while we were doing this work, Hani was supported by a National Hemophilia Foundation Shire Clinical Fellowship Award. So thank you to the National Hemophilia Foundation for supporting this work. And then I mentioned my current research mentor, Carolyn Bertozzi at Stanford, as well as research assistant, Katie Tiemeyer, who I've been working hand in hand with on the GP1B alpha studies. And then I mentioned our collaborators, Stacy Malakar at Yale and her colleagues, and Kazuhiro Aoki and Mayumi Ishihara at University of Georgia. And then I'd also like to thank funding for this project, including funding from National Blood Foundation and the NIH and internal funding at Stanford. With that, I'm really happy to take any questions, and I'm also leaving up my Twitter handle here in case anyone would like to connect afterwards on Twitter as well.
Oh, that's perfect. Let me go ahead. I'm actually going to, in the chat, throw your Twitter handle as well. Okay. Just give me 1 second, because I think that would be great to make sure we have that shared out. Okay, so I do have a couple questions for you. We're going to start with one that's in the Q&A. And if anybody else has any additional questions, you can go ahead and throw them in the chat. We're also monitoring our social media platforms for anyone that wants to ask something there, wherever you're streaming from. Okay, our first question, it says, I have von Willebrand's disease that has appeared, in quotes, to go away while on gamma globin IVIG for my immune deficiency, yet I still have very serious bleeds. I was also diagnosed with lupus anticoagulant. Could I also have ITP despite having a normal platelet level? Could the platelets just be damaged, and how do you test for that?
Well, thanks for that question. I first of all will say, it sounds complex, and so probably hard for me to completely weigh in on all of the details of this case with just this small bit of information. But I would say that really a hallmark of ITP is the low platelet count, and so if your platelet count is normal, that would sort of by definition indicate that you don't have ITP. But certainly, it sounds like a complex scenario with a lot going on that probably warrants further investigation. I would say that, I didn't highlight all of this data, but in general, there is, even in healthy populations, some positivity for all of these different autoimmune markers, including the lupus anticoagulant. So just having positivity for an ANA or a lupus anticoagulant in the absence of any clinical features of concern wouldn't, kind of label you with a specific diagnosis. So generally, a lupus anticoagulant is of concern for a patient who has thrombosis rather than bleeding. And so I would be, I guess, less concerned about lupus anticoagulant being relevant if you haven't had a history of thrombosis.
Great, thank you. So what were the greatest challenges in your research?
Oh, that's a great question. Well, I would say that I think a challenge for doing any type of retrospective clinical study is just really putting all of the data together. So even though Dr. Cooter, we're very advantaged to start off with him having really great records on his patients, it was still quite an effort to really just assemble all of the data, honestly, and it required a lot of just manual review of the charts, for example, to figure out if the patients had a thrombotic event or not. I manually went through the charts and looked at the patient notes and radiographic studies, and that is just very time consuming. So I would say that's probably one of the major things, is just the time that it takes to go through and manually look at all of that. I think with more and more electronic health records, the hope is that we may be able to do this type of study more easily. But I think that as things stand, a lot of the information that we want for this type of study is not something that's like captured in a readily available way in electronic health records. So we still do a lot of manual review of charts for this type of study.
Great. Do you have any additional next steps in your research? Do you have any ideas on how you might build on your findings?
Yeah, well, so I would say that I'm most excited about moving forward with the work that I showed at the end. That's kind of the current things that I'm working on. And I think, to me, really trying to understand more about what these anti-glycan antibodies are in ITP patient sera, that's really interesting to me. And I'm really interested in trying to understand if these autoantibodies, for example, are they just targeting that specific TF antigen that I showed you, that carbohydrate structure, or are there antibodies that recognize that TF antigen only when it's in a certain context, like only when it's attached to the protein GP1B alpha? Those are the types of questions that I'm really interested in studying, because I think the more we can understand about really the molecular features of the antiplatelet immune response, I think the more window we will have into developing better diagnostic tools for ITP and potentially even better ways to prognosticate in ITP, which would be really helpful.
Great, thank you. How would you suggest that community members could participate in a similar study?
Oh, that's a great question. I would say that I think I don't have a great answer to that. I think it relies on like where you're going for your ITP care. I would say in general, if you're going to more of a major academic center, it's more likely that they would have this type of study going on. But that being said, many patients receive care for their ITP outside of the context of a major academic center and receive really outstanding care. So I guess I would say probably if you're particularly interested in participating in any type of research, seeking care at an academic center would probably be the way to more likely have that happen.
Great. Were there any conclusions from your study that you were relatively surprised by?
Well, to be honest, I was pretty surprised that we saw just such a high rate of autoimmune marker positivity. So the 77% was quite high, even though we did expect it to be high. And I guess the findings with the ANA, I think being so robust in the Kaplan-Meier analysis, I think that was also kind of exciting and surprising that I do think we saw a pretty robust statistical association between ANA and thrombosis. But then it was similarly a surprise that the Carmen registry didn't replicate that. So I think it's, I guess it just goes to show that you have to be careful about any of your hypotheses. You have to really gather a lot of data to be sure whether something's true or not.
Great. What is the biggest takeaway you would want the audience to walk away with from your talk today?
Yeah, I think the biggest thing would be that we really need more information about autoimmune markers in ITP, that they're potentially promising in the future to use to help us to determine patients' prognosis or treatment plan, but I think not quite ready to be used. But I do think that there may be in the future an expanding role for the anti-platelet autoantibody tests for making a diagnosis of ITP. And so I think I would look out for that being more and more incorporated into practice in terms of making a diagnosis of ITP.
Great, and I have just one more for you. Where is the best place to get help for complex bleeding disorders?
Oh,
It's a big one.
too. I mean, I would say that it varies a little bit based on where you live, but again, I would say most major academic medical centers will be a good place to go. Some places have hemophilia treatment centers. I think there's variability across the country in terms of what specific types of patients are seen in hemophilia treatment centers, like whether or not ITP would be included in that. I can speak, at Stanford, we have a hemophilia treatment center that sees patients with hemophilia A and B. And then in our standard hematology clinic, outside of the hemophilia treatment center, we see patients with ITP, von Willebrand disease, and I think we do a great job of that here. But I also think there are many different places where you can get really outstanding care. Probably if your case is very complex, you should, again, go to an academic center.
Great. All righty. Well, I'd like to thank you once more for taking the time to join us this afternoon. We appreciate your time and expertise. That was some really incredible information.
Thank you.
Yeah, I'd also like to thank each one of you for joining us on whatever platform you are streaming from. Please note that this recorded webinar will be available on Friday, August 5th at hemophilia.org under the events tab with all of our archived webinars. Also available in the events tab is our upcoming schedule for our weekly Wednesday webinar series. Thank you for joining us this afternoon and have a wonderful week.